Well, I wasn't going to start this night with a question, but I think I'm going to start this night with a question. And that is, raise your hand if this is the first time attending this Sharing is Caring event. Wow. Okay. And lower your hand and raise your hand if this is your second time or third time attending. Wow. Okay. Well, this makes my introduction a little bit easier because my first statement was welcome to our third annual Sharing is Caring event. So this is either your first year or perhaps your third year. Regardless of what year it is for you, welcome. It is our absolute pleasure to host you this evening at the University of Ottawa Heart Institute. My name is Dr. Jennifer Reed. I'm the chair of our cardiac rehabilitation program here at the University of Ottawa Heart Institute and the director of the Exercise Physiology and Cardiovascular Health Lab. It's a long name. We call it the EPCHL, but that's neither here nor there for this evening. The idea for this event was born from discussions during our cardiac rehabilitation heart team meetings, where we brainstormed how we could enhance and expand sharing our clinical research using educational practices. Most academic or scientific outputs are shared by way of peer-reviewed publication or academic conferences. While these formats are important for the medical and scientific communities, only a small percentage of those who may benefit from the research will read these works or attend such gatherings. We are here today to bring some of our works directly to you for those that may not read these peer-reviewed publications or attend these medical conferences, which is many, both in our community and beyond across Canada and the globe. The idea behind this event, Sharing is Caring, emerged, and the name was specifically shaped by my two young children, toddlers, a few years ago, as I find myself using this refrain on a nearly daily basis. Sharing is caring. And now I have the pleasure of using it here for you tonight. As I mentioned, this is our third event. We hope for this to be a regular tradition to directly share research outputs from scientists to our patients, their caregivers and families, and community partners. The public at large is where we want to share the research that's being done in this building with you here. Your responses to the feedback questionnaire, which is the table with the food. So if you find the food at the end of the night, you'll know that there's a questionnaire waiting for you if you can spare us a few minutes to complete the feedback. Our speakers this evening, we have 3 presentations to start off the event. Then we will transition to a moderated panel, our secret sauce that was not in our brochure, but I hope you'll find that it will be quite enjoyable. And then following the moderated panel, we will move to the track, our cardiac rehabilitation track, where you'll find educational booths to interact in a more personable and approachable manner with our researchers, our administrators, our staff, and everyone that's here this evening to welcome you. Starting off our presentations is a dear colleague and friend, Dr. Karen Bouchard, an associate scientist and director of the Social Connections Lab. She's also an assistant professor in the School of Epidemiology and Public Health in the Faculty of Medicine at the University of Ottawa. She's been known to tell a few good jokes, so find her at her table afterwards. Following Dr. Bouchard's presentation is Dr. Lisa Marie Mocal, a postdoctoral research fellow in the Cardiovascular Health, Psychology, and Behavioral Medicine Lab here at the University of Ottawa Heart Institute. And our third and final presentation is Dr. Chelsea Moran, a clinical and health psychologist at the University of Ottawa Heart Institute and an assistant professor, a newly minted assistant professor in the Faculty of Medicine at the University of Ottawa. They bring expertise to this event, to your Heart Institute. We have over 150 individuals registered for this event in this hybrid format. Some are online this evening, the rest are here in person with us. I would like to start off with our land acknowledgement. And please excuse me while I try to advance the slides here. Perhaps those in the back will help me. There we go. The University of Ottawa Heart Institute acknowledges the unceded traditional territory of the Algonquin, Anishinaabe, and people of the Algonquin Anishinaabe Nation. We recognize all Indigenous people in the region from all nations across Canada who have also made Ottawa their home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation. Together, we take responsibility for the heart health of all people in the region. This event would not have been possible without the support from our speakers, our clinical research teams, and our patient partners. You'll have the opportunity this evening to meet some of them. So with that, it is my pleasure and honor to welcome up our patient partner, Stephen Stewart, to share a few words to help us kick off this third annual event. Thank you.
Thank you, Jennifer, and good evening and welcome to everybody in the room and everybody online as well. Thank you for being here. It's the third iteration of this very special event, and I'm very happy to have been associated with it and working with some excellent people here in the Heart Institute. So I've been asked to remind you that plain language summaries of all the presentations in both languages are going to be available to you. You should have them already. And also you've been given some pens to take some notes as we go through the presentations, so that when we go through to the track and the information booths, you can ask questions of the people there that have maybe been prompted by what you've heard here. So my name's Stephen Stewart, and for the past 17 years, I've been associated with this institute as an outpatient, as an inpatient, as a surgical alumni, and a participant in the institute's amazing and life-altering cardiac rehabilitation program. So I'm fortunate over the years to be able to give back to the institute in a variety of ways. As a member of the Research Ethics Board, I get to read about much of the institute's incredible research. I am able to contribute aspects of my lived experience with heart disease to various research teams as a patient partner. And I can participate in this, the third iteration of the wonderful initiative that is Sharing is Caring, which brings the results of some of the Institute's latest groundbreaking and world-class research on diverse aspects of cardiac rehabilitation to you, from fellow patients, her caregivers of patients, and community partners. And the presentations are in plain language, which makes it accessible to a wider audience, and it allows the research to be mobilized in particular ways to a wider, more diverse audiences, increasing its impact. And that's really important, is making sure that the research actually lands and has impact in communities amongst people who need to get the results. And in a world where increasingly people turn to the internet and to chatbots for medical advice, in inverted commas, the need for rigorous and evidence-based medical research has never been greater. And so the work that the Institute is doing here is of real profound importance in our world. So this event will surely increase the factual knowledge base on cardiac rehabilitation in the wider community via plain language presentations, by the fireside chat, in the educational booths promoting various aspects of cardiac rehabilitation program here at the Heart Institute. So thank you for being here tonight, and thank you to the amazing team of people who worked so hard to make this evening so inclusive, informative, and stimulating. So it's the end of everything I have to say, and it's my pleasure to invite Dr. Karen Bouchard to come and make her presentation.
Okay, so the opening act, pressure's on. Okay. Sorry, I'm just gonna, okay. There we go. Okay. So thank you very much for the opportunity to speak with you today. So I'm actually going to be talking to you about a study that I published this morning. So just in the nick of time. So it just landed in the Canadian Journal of Cardiology, and I'll have a QR code for you at the end. But so it was perfect timing for this event. Okay. Sorry, we're just working out here the slides. Okay, so before we get started, I want to ask you and the people in the computer a few questions. So I want you to think about whether you have ever worried about how your health affects your family, whether you've struggled to explain something difficult or emotional to a child, and not necessarily your own child, but any child in your life, or whether you have ever tried to prevent a child in your life from worrying. So with those questions in mind, we're going to do something a little bit fancy. So bear with me here. What I'd like for you to do, for those who have phones in the room, what you can do is actually scan the QR code, and what it's going to bring you to a page where you can now vote if those are things or questions that you've asked yourself in your life. It may ask you to put in a name. You can just put in whatever name you want. It doesn't matter. And what we'll see, the magic will happen on the next slide where we'll get to see what everyone has voted. And if it doesn't work, we're just going to do a show of hands. See it? Ooh. Okay, we'll just give another 20 seconds. And apologies if you're not able to do it in time. Hey, it's just so addictive watching it, isn't it? So it looks like from all of this, it seems as if most of us have experienced worrying about how our health affects the children in our lives. And as well as the other things, struggling to explain something difficult and trying to protect children from worrying. So tonight I'm going to be speaking to you about our research that closely relates to these things. So we conducted some research with parents who had early onset cardiovascular disease and what their concerns were as parents. So for a little bit of context, so why am I studying this? We know that early onset heart disease is actually rising globally, and it's increasing from 1.5 to 2.6 million cases over the last few decades. And those are ones that we've reported, so you can imagine it's much higher. So what exactly do I mean by early onset heart conditions? So in the scientific literature, it's typically defined as a heart condition that occurs before the age of 65 in women and the age of 55 in men. So as you can imagine, these are heart conditions that are affecting people as they are raising their children, as they are working, as they are caring for ailing parents. So most of what we know about parenting during chronic illness or serious illness comes from research in cancer or in palliative care. So when we look at this body of research, it shows that when a parent becomes seriously ill at a younger age, it can disrupt family routines, it can change parent-child dynamics, and it can create emotional strain for children. However, these have been largely explored in the context of cardiovascular disease, which we know is a different experience. So what we did is we really wanted to know what are parents' biggest concerns when navigating an early onset heart disease diagnosis or event. So what did we do? We asked Heart Institute patients and their spouses to participate in a qualitative research study. So what they did is they filled out a socio-demographic questionnaire so we could learn a little bit more about them. And then they participated in a focus group. Oh, he's taking a picture of me. So awkward. And they participated in a focus group. So it was a 90-minute session with parents who've all experienced a heart event or have had a cardiovascular disease diagnosis, where we have an interview guide and we try to learn a little bit more about their experience. And then we do some fancy magic, some qualitative analysis strategies where we group things that people say together so that we can better explain our results. So who participated? We had 32 participants in total. About 8 of them were spouses of patients as well. So we had both perspectives, and the average age was 47. Some were patients living with the coronary artery disease, spontaneous coronary artery dissection. If you know what that is, it predominantly affects women who are younger in age, but also people who had rhythm disorders and valve disease. And importantly, all of our participants were parents to a child within their home who was under the age of 18. So what did we learn? We learned that parents had 3 chief concerns. The first concern was communicating the event or diagnosis to their children. The second was fulfilling a parenting role. And the third was parents were concerned with children's physical, emotional, and social adjustment. So now I'm going to go into each one of these into a little bit more detail. So for the first concern, parents weren't really sure how much to tell their children, especially early on when the details were very unclear. They wanted to be honest without causing fear, and they were adjusting what they were saying based on their child's age and developmental stage. So some chose to explain things clearly right away, while others didn't want to overwhelm them all at once. And what we found that was most striking is that most wanted to have more guidance on how to have these conversations with their children. So here's an example of a quote. So the first one is from a patient who is also a father. So we wanted to make sure that my daughter was informed to the point where I'm not misleading her or anything, but at the same time, I did not want to trigger worry or overload with details. And a mother said, I'm afraid I'm going to show too much of my own nervousness and fear. So communication was a very prominent thing that came out in these focus groups. The second concern was that parents described feeling unable to fulfill their parenting role. So they described struggling with low energy and emotional strain, which made everyday parenting much harder. Many felt a loss of confidence or presence in their parenting role, along with fears about not being there for their children as they grow up. So here are some quotes here. I'm tired and exhausted and freaked out. I'm not what I was. And that was from a mother in our focus group. I was always doing something with them all the time, but then I had to take it slow. That was my biggest thing, how active I could be with them. So identity concerns were a big thing that came out. And so the final concern had to do with children's physical, emotional, and social adjustment. Parents were really worried about how their children were coping, physically, emotionally, and socially. Many became quite vigilant about their own child's heart health. Um, they also noticed disruptions to routines and activities, often because their own energy and availability changed during recovery. So here are just a few quotes. I do worry that she's internalizing because she's worried. He started to isolate himself and he wasn't as vocal. And then another parent said, I think that's the biggest worry, that now we're just passing these genes on to my kids. Okay, so what does this all mean? Firstly, it means that parents with early onset heart conditions have a lot to grapple with. They have several challenges that go beyond their own heart health, right? So what can we do to help? First, parents may benefit from participating in support groups with other parents who have similar experiences, because we know that can be really helpful. Second, it may actually be helpful that we start screening for family-related distress in programs like cardiac rehabilitation, so we know what parents might need a little bit more support. And the third thing is that we actually can start training health professionals, especially in more adult-centered centers like here in the Heart Institute, to more training and family-centered approaches so that they can actually be, they can help these families navigate these difficult conversations and provide the appropriate support. Okay, so take-home messages. Parenting while navigating an early onset cardiovascular condition can be challenging is number one. Number two is that parents really do want help addressing these family-related challenges. And number three, and I'm not just saying this because I'm a researcher, but more research is clearly needed, especially within the cardiac world. There's been so few studies, so it's really important that we look at this. And in terms of resources, we actually took the data from the focus groups and we developed a guide for how to discuss heart conditions with children and youth. And within the guide is a super fun, this was really fun to make, a glossary of cardiology related terms, but all spoken in a way that, you know, a 5 to 10-year-old child can understand. So I actually found it very helpful. But so it's something that a parent could use if they're trying to explain like what is an ablation, you know, so it's it could be very helpful. And this is the article that just was published this morning. And I just want to say a big shout out to my postdoctoral fellow, Dr. Laura Quintero Silva. This is her first author paper. So it's very exciting for her. And where is she sitting? Oh, she's standing over there. Good job, Laura. Stephanie. And am I introducing Lisa? Okay. Yeah. Lisa, do you want to come up? Okay.
Good evening, everyone, and thank you so much for being here tonight. Have you ever wished for a little extra help at home to manage your health? Maybe someone to remind you to take your medications, or to encourage you to stay active, or maybe to just keep you a little company. And what if technology could provide that kind of support? Today, I'll be talking about social robots and how they can help people at home. Let's take a look.
Oh my lord! What's that?
Hello, my name is Pepper. I'm here at your service.
Are you? Well, do you know Dr. Mitchell, my doctor?
Dr. Robert Mitchell? Would you like me to book an appointment for you?
Well, that would be brilliant. I am Rebecca Parker.
He is available at 11:30.
That would be perfect. It's just before lunch.
Yay! Appointment confirmed. Don't forget to do your daily exercises.
Pepper, it seems I have a new friend.
Yeah, thanks, Pepper, for this introduction. So, social robots are interactive devices designed to help people in their daily life. And they can help track health information, for example, blood pressure or heart rate. And they can also give reminders to take medications or do gentle exercise. They can help schedule appointments and communicate with healthcare teams. And in some cases, they might even provide companionship or emotional support. And social robots are already widely being used in people living with dementia. And studies have shown that they can increase medication routines and the overall well-being. And as we probably all know, they are widely used in countries such as Japan. But experts believe that they are very likely being introduced in our healthcare system in the near future. So a quick question for you all. If a social robot were available at home, would you actually use it? And you're already familiar with the system, I guess? You could also reopen the page you just had. It's the same code, and the question should be there. Well, I take the 100% and fine, but I'll wait a few seconds, I guess. Okay. So I get the sense that the majority would really like to try it out. I'll come back to this later. You might be wondering, why study social robots in heart failure? Or maybe you are asking yourself, what exactly is heart failure? When people hear the term heart failure, they often think that it means that the heart has completely stopped working. But that's not the case. It means that the heart is weaker than normal and cannot pump blood as effectively as the body needs. And because of that, people may feel short of breath, especially when they move around or they're taking steps. And they may feel especially tired or notice swelling in their feet and legs. And why is heart failure challenging? Heart failure is a serious and long-term condition, and it affects millions of people worldwide. And many people living with heart failure, they have frequent hospital stays and also many doctor appointments. And they really need a good daily self-care management to handle all these multiple medication, for example. And many feel tired, overwhelmed, or limited in their daily life. And this is especially true for older adults and people living with multiple health conditions. So when it's getting even more complex. So a big question in heart care is always, how can we better support patients at home, not only here in the hospital? And that led us basically to our research question. What do people with heart failure think about using social robots at home? And what features would they actually like? And to answer that question, we invited adults with heart failure from the University of Ottawa Heart Institute and to take part in our study. And first, we showed participants 4 videos of social robots. The video we just watched was one of these examples. And the goal was just to give an idea about how this social robots could actually help at home. And after watching the videos, patients filled out a short set of questionnaires. We had 101 participants, and about 40% of them were women. And most participants were around 68 years old, and most had been living with heart failure for 11 years already. And in our questionnaire, we ask about basic information like age, sex, and education, and whether they lived in a city or in a rural area. We ask about medical information, so how long they've been living with heart failure or about all other health conditions they might have. Then we ask about their attitudes toward technology in general and social robots in specific. We were also interested about any privacy concerns they might have. And importantly, whether they would actually use a social robot. And to measure willingness to use a social robot, we used a well-known framework that asks questions such as, would this technology help my health? Would it be easy to learn? Would I have enough support to use it? And would people that are important to me approve it or like it? Let's have a look at the results. So before the study, most participants had little or no awareness of social robots at all, and only 7% had ever interacted with one. Despite this, around 70% said that they would be willing to use a social robot if it were available. So a bit similar to what you just voted. And who was more or less willing to use a social robot? People living in urban areas were more likely to see social robots as useful. And on the other side, older participants were more concerned if they could actually learn how to use them. And what features mattered most? Patient gave us a clear impression of what they want, and here are just some examples. But health monitoring was the top priority. So in particular, blood pressure tracking was rated as useful by 87% of our participants. And appointment scheduling was also seen as helpful. Interestingly, companionship was less important. About 50% felt it could be useful. And all kinds of invasive tasks, such as performing nasal swabs, were the least appealing, understandably. And when it came to data sharing, 85% were comfortable sharing robot-collected data with their healthcare team, but 30% would not share their data with cardiologists. And a small group did not want to share their data at all. But this reminds us that privacy and choice really matters. So what's next? Next, we are looking at psychological factors that might influence how people with heart failure think about social robots having at home. And we're not only focusing on the negative aspects or about challenges like anxiety and depression, but we are also interested in the positive side. So things like hope or optimism. And the goal is to better understand who is most likely to benefit from having a social robot at home. And then our engineering colleagues who also collaborated on this project with us, they will use all this information to then build a prototype of social robot, one that truly reflects what patients want and need. My take-home message is social robots can support care at home, and patients are generally open to use them, and they know what would work best for them. And any design must start with the voices of patients. And here you can find the original scientific publication behind the work that I've shared with you. And as already said, we will have copies available for you at the booth. And we've presented this work on different places, locally, nationally, and internationally. So it really means a lot to bring it home back to UHI tonight. Thank you very much.
Okay, hi, good evening, everyone. I'm happy to be here this evening with you to share some results on this research study that actually I collaborated heavily with Dr. Karen Bouchard on, who who presented earlier. I'm less happy to be following up those two other amazing presentations. So we'll see. I'll do my best to measure up. And so what I'll be speaking about today is, when someone has a heart attack or a heart surgery or some kind of heart-related issue, one person almost always shows up with them, often a spouse or a partner. They help remember instructions, they help manage medications, they hold things together at home while the patient is in hospital, they support them emotionally, among many other helpful support responsibilities. So today I want to talk about that person specifically. We call these people spousal caregivers, and I want to talk about what we've learned through this research about their physical and mental health. So I'll start off by asking everyone in the room here, I think everyone's familiar with our QR code here if it generates. If not, we'll do show of hands. I'm wondering how many of you here have been in a caregiving role yourself. Now, this can be caring for someone with a heart condition, of course, but it can also be caring for someone in your life with other medical conditions, mental health conditions, parents, children, whatever the case might be. So I'd like you to think of this more as a wide category here, not just with heart conditions. Oh, it's not loading. Okay, well, how about we do show of hands then? Yeah, let's do show of hands for this one, if that's okay. Okay, yeah, a lot. I'm glad we did that because most people in the room are raising their hands. And, our response rate here too was 100% as well, but I don't think that's as representative. So, we'll take it. We'll take the hand vote. So many of us have been caregivers. Maybe even if you have not identified that way until today, learning that term. And sometimes, that might change. That role might change throughout our life. We might be caring for someone at one point in our lives, and then maybe we need more support, and someone is caring for us. And so most of us will be in this position at some point in our lives. And so even more important to be speaking about the mental health and the physical health of the people doing that important role. And so what do we know about this? So we know that heart disease, coming back to heart disease specifically, we know that heart disease affects the whole family unit. I mean, of course, we just heard from Dr. Bouchard about that too, specifically with children, but it affects the whole family, not just the patient. And oftentimes spouses and partners become our heart patients' primary caregivers, mostly because they already live with the patient, they already have a strong bond with the patient, they care for the patient, right? They care for their spouse most of the time, I guess. And caregivers are also a critical part of someone's medical team and support system. I really emphasize the point when I talk to my patients and their partners or their caregivers that you are also part of the medical team. You also provide, just as important support as the doctors, the nurses. You're the one who's showing up for the patient every day in between appointments when things are tough. And spousal caregivers specifically do a lot. And, I'm not going to be able or have time to summarize everything, but I kind of think about it as different types of support that they offer. They might offer practical or instrumental support to our patients. What I mean by that is help with tasks and logistics. Who's driving the patient to appointments, who's reminding them to take their medication, who's picking up their prescriptions, and so on. They might also provide emotional support, so helping with talking with their spouse or the patient about maybe their fears related to their health, the uncertainty, and all those the emotional distress that could come with living with a heart condition. They might also provide information and guidance support, so that's more so looking at helping with understanding medical information, maybe attending appointments with the patient, having kind of a second set of ears on things, helping make important decisions about treatment options and ways to move forward. And especially when we're talking about spousal caregivers, this is someone that for the most part knows the patient the best, perhaps, in their lives. And so they really know about their values and how to provide that support to make those important decisions. And then caregivers, of course, it's not all just about the heart and the health. They're an important positive presence for patients, helping to reduce loneliness and increasing a sense of connection. So as I said, this is not capturing everything, but it's just to point out the variety of the different tasks and roles that caregivers might bring on and how, or might take on, and how important that is. And so what's the issue with this? It's, very meaningful to be providing this service and this care to a spouse who is having a heart condition. So while caregiving can be meaningful, it can also be, of course, a big responsibility. It can be stressful, it can be demanding. Often the caregiver's health themselves is overlooked. And I would say, especially in the research literature, we don't know as much about caregiver health compared to the patient's health, of course. And often caregivers themselves often feel that they have to put their own health kind of on the back burner while they are caring for the patient. And so we hear a lot about how patients are doing, but we hear less about how caregivers are doing. Now, you might recognize this image on the screen here from airplane safety briefings. If you've ever taken a flight, they say a lot of different things that might be, frightening in the case of the worst case scenario. But one of the things they talk about is in the case of depressurization in the cabin, if there's low oxygen, these masks will pop down. And they always say, put your mask on, your own mask on, before you help anyone else with their mask. And of course, when I first heard that, I found that a bit counterintuitive. The tendency is to help the other person first before we help ourselves. But then what happens if we don't have enough oxygen then to help the other person? So when it comes to in caregiving, the opposite often happens. Spouses focus entirely on the person with the heart condition. They might ignore their own needs, maybe defer things for sometimes months or years while they're helping their spouse. And again, this makes sense because they're kind of that person to go to in crisis and to provide that care. But then this metaphor reminds us that taking care of ourselves first is not selfish. It's actually critical for us to be able to keep providing that care and support for the patient, for our partner. And so for the study, I actually had the benefit of using some information from a study that was conducted by my colleague, Dr. Heather Tulloch, and her team. And so she's a fellow psychologist here at the Heart Institute. And so her team conducted a study where they surveyed couples who were participating in cardiac rehabilitation. So they recruited patients who were in cardiac rehab and then surveyed both them and their spousal caregiver. And so I had the benefit of using that information, and I was interested in comparing specifically patients and caregivers on their physical health status that they self-reported, their mental health status, and also their health service utilization, specifically when it comes to medications or mental health services that are being used by each the patient and their spousal caregiver. And we compared this information using some statistical testing that tells us whether differences are significant and not merely due to chance, in order to see, how might we compare, how's the health of our caregivers, but also how does that compare to the health of our patients? And so we surveyed 151 caregivers. 3/4 of the caregivers were female. The average age was about 62 years old, and the majority identified as white. And so the main findings were that overall, caregivers were physically healthier than patients, which of course, maybe we didn't need to do a study about that. That makes sense given that our patients have, serious heart conditions. It makes sense that perhaps their caregivers are physically healthier. However, this does not mean that caregivers were free of health challenges themselves. About 2/3 of them reported at least one physical health condition, such as chronic pain or muscle and joint problems, which of course are unpleasant to live with, but also could make caregiving more difficult, especially those more physical tasks. Our second key finding was that caregivers were not mentally healthier than patients. What I mean by that is in our sample, the caregivers were more likely to report having been diagnosed with a mental health condition, more commonly depression or anxiety. About 22% of the caregivers reported a previous mental health diagnosis compared to 14% of patients. And that difference was statistically significant. And despite this, only a small proportion of the caregivers were currently receiving mental health services or mental health support. And so this is significant. There was no significant difference between caregivers and patients in that regard, but this is a significant finding given that caregivers were reporting higher levels of mental health conditions. And they were receiving, only a small proportion were receiving support. So what does this mean? Of course, caregiver health matters too. As I mentioned, caregivers are such an important part of our patients' care team, and also an important part of our patients' lives, and our people themselves too, who deserve care and support and resources for difficult things that are happening in their lives, including caring for their patient, for their spouse. Ideally, caregiver support could be built directly into our cardiac programs. Right now, that's not possible due to capacity issues and so on. However, that doesn't mean that as care providers, we cannot do anything about caregiver health. Realistically, I think right now the best way to support caregivers when we are meeting with our patients and perhaps also their spouse is to ask them how they're doing as well and offer information about support and resources that are available, maybe within the hospital, but also outside the hospital in the community. There are many mental health resources available and also many caregiver specific support groups and resources that could be helpful to help ease that strain or, you know, the difficult part, the stressful part of being a caregiver. And so in light of that, at the Heart Institute, I was not involved in creating this guide, but I just wanted to highlight a recently published guide about living well as a caregiver. And so there is a lot of information in here about some of those resources. I also included some mental health resources and mental health focused caregiver resources in the lay summary package related to this presentation. And here is the screenshot of the article, which will be available at the education booth after the presentation. And again, just want to thank my co-authors, Dr. Bouchard, Elisa Stragapede. I always mess up her last name. I'm sorry, Elisa. And also Dr. Heather Tulloch. Thank you all for your attention.
How's everyone doing so far? Good. So just a reminder, if you have questions that you thought of during the presentations, we've given you a pen and everything is printed on single-sided so you can write your questions on the back and then you can ask those questions at the educational booth time. So don't lose sight or hope that you won't be able to have some of those specific questions answered during this evening. All right, we are moving on to phase 2 of this event, which is our moderated panel. I would like to introduce Joel Haslam. I'm sure many of you may know the name. You may have seen him on CTV for many years, but he is a key figure in our community. He has been sharing our stories, your stories for many, many years, and we couldn't be happier for him to accept our invitation to moderate the panel. Who better to connect us with our researchers and the community than Joel? So Joel, please come on up.
Thank you so much, Jennifer. Hi, everybody. So good to see everyone. I'm always excited when I can see over the podium. It's a good day. I'd just like to begin, first of all, by welcoming everyone and saying a big thank you to everyone here in the Feaston Ellis Auditorium and to people who are online at home because, you know, it's a busy world, it's a busy life. And I think by being here tonight and by taking time to tune in at home, you're honoring the wonderful 50 years of research, patient care, and life-changing work that is being done here and the people who do it. So I think it's been so fascinating to listening to the presenters tonight, and I'm so grateful for the opportunity to moderate tonight and to pose some questions to the very exciting people involved. So without further ado, I'd like to make some introductions. I'd like to begin by introducing the CEO and president of the Ottawa Heart Institute, and also someone who happens to be one heck of a rock star. If you've never seen him perform in his band, The Phenotypes, you have to check him out sometime. Dr. Rob Beanlands, please. And I'd like to welcome the Ottawa Heart Institute's Chief Scientific Officer, Dr. Katie Rayner. Katie. I think you're a rock star, Katie. Anyone who knows your work would agree. So this is great. We're going to have a fireside chat without a fire, but we're going to do our best and improvise. I'm going to ask some questions, and Dr. Beanlands, I'm going to begin with you tonight. When you look ahead 5 to 10 years from now, what new discoveries or technologies in prevention and rehabilitation, which of those excites you the most? And what big questions do you feel we still need to answer?
So what excites me a lot, and first of all, thanks, Joel, for thanking the audience. I wanted to also express my appreciation to those of you who are here as patients. We really, really appreciate you coming, and you are why we are here. And for those of you who are healthcare providers, for the work that you do every day to help us and to help the Institute and help us help people be better. And it is our 50th anniversary, as you pointed out. So we're very, very pleased to have the audience here today. What I'd say is the things that excite me about the future are some of the things we actually heard about here this evening, is how we are trying to better understand patients and their families and reaching out to the community more and more. And I think this is the emphasis on prevention is really, to me, what is going to help us improve healthcare overall. I think people know that healthcare is being challenged financially, delivery and access. But if we can focus on prevention more, we can intervene early and potentially save lives, delay events, and improve quality of life. So that's something that really excites me, that we're thinking about that. We're also thinking more about how we reach the whole community, the concept of heart health for all, that we're really trying and focusing more and more on the heart health of the whole population, the diverse community that we serve. And I think you saw some of the, as well, the exciting, the robots, other data and artificial intelligence, wearables, your watch, your phone, and all the data that we can use to help inform us, but being able to do that with a human touch. Like, I think these are the things that excite me a lot about the future. At the Institute, we've just embarked on a big campaign called 1 Million Hearts, which is really a bold goal to try to screen 1 million Canadians for heart disease, and in an effort to try to prevent it, which will reduce the likelihood of events down the road and help people live healthier lives. We also want to expand our focus on prevention, the impact of climate, women's heart health, and also education. I think sessions like this really help us to focus on how we educate each other, how patients can tell us what's important to them, and how we can better deliver care. So there's my long, short answer.
That was a wonderful answer. Thank you. Would anyone else like to comment on that question? Katie?
Sure. Yeah, so I think that one of the things that excites me the most, I think, is quite specific to our region and our audience. I think I can tell from you all being here tonight that you care about learning, you care about knowing more. So that is the spirit of what we do at the Heart Institute, is we always want to know more. We could just be a hospital. We could just take really, really good care of your hearts, but that's not enough, right? We don't want to just do that. We want to know more. We want to know why. We want to try new things that will make things better, earlier, sooner, smoother, whatever, or all the ers. So I think what I look forward to the most, actually, or what I think is going to be really impactful, I do think that we have a possibility in our region to actually identify new things that are causing our hearts, to either, have heart attacks or whatever it may be, and actually prevent them. Because I do think that the community is engaged. Knowledge will tell us what to do. We need the information. We need to be able to know what's lurking, what's hidden. And I think our community is really, really going to latch on to that and going to get really excited about that. And when we can know that information, we can make discoveries that, we can't even predict at this point. We can't even understand yet what might be lurking and what might be causing, heart disease and other risk factors. So that's, I think, what I see in the next 5 to 10 years, a really, really healthy region, because we've decided that heart health is really important to us, and we've managed our risk factors, and we've understood more, and we've done something about it.
Jennifer?
I'm going to pick up on the technology point because I think it's a really important aspect of future care. This event this evening, we offered in a hybrid format. Many of you are sitting right here in front of us, but there are also many online this evening. And the Champlain Local Health Integration Network is very diverse, urban, rural, those that speak different languages. The demographics of those that live in our region is also very varied, which is a strength for us at the Institute in terms of examining cardiovascular care. But the technology aspect, if we harness available technology and work to improve it, I think our greatest stride, or one of our greatest strides and needs, is delivering care to those that cannot come here. Many individuals can, but many individuals will choose not to come here for a variety of reasons. We live in Ottawa. How many of you just came through the polar vortex? Mostly all of you. So it's really important that we find ways to bring care to every single individual who needs care. It should be equitable, and it should be available to everyone, no matter who you are or where you're from in the region. And so harnessing technology to enable us to bring our care directly to your home in whatever format best suits your needs, I think that is something that we need to focus on in the next 5 to 10 years, and where a lot of our research efforts in prevention rehab are also going. And to the shout out to 1 Million Hearts, we have Courtney in the back with the red t-shirt, one of the many red t-shirts. We do have a booth for 1 Million Hearts this evening, and they are opening it up to Beyond staff. We're moving into the phase Beyond staff. So get your name on the list, speak to Courtney, bombard her with all of your questions tonight when we move to the educational booth.
And I can say that Courtney actually did my 1 Million Hearts screening. Fantastic, Courtney. She was amazing. So thank you very much. Stephen, I'm wondering if you could speak to that. And I'm wondering if technology has impacted your care.
Yeah, and I think the technology side is interesting. And I think we're seeing rapid advances in technology in so many different aspects, and the amount of data that's being collected allows new diagnoses to be discovered because of the population-wide level of data that's there. The thing I think is most interesting and is going to be most exciting over the next 5, 10 years, whatever the time span is the inclusion and the possibility of including more lived experience in the research. We've heard a lot tonight about the work that Dr. Bouchard's and colleagues have been doing, that have been looking at caregivers and this kind of thing. And in my experience, I got some fantastic care in this institution, and I continue to get that. But the support mechanisms that were in place when I first got sick, there was no support mechanism. There was no recognition of the burden that it put on my family. And so my lived experience is one thing. Everybody else's lived experience is unique. And we live in a very multicultural society, very diverse society. So what works for me and my family in this situation doesn't work for probably anybody else in this room. And technology is going to allow these kind of bespoke regimes to be understood and put in place, I think, much more so than they are currently. So that's what I find exciting, is the core science is going to be really good, but the lived experience of individual patients is going to be allowed to be used to tailor that treatment, not just to the person who's sick, but also to the people who surround them. Because in my experience, I got some amazing treatment here, but the support of my family was paramount, going through the anxieties and all of this kind of thing, as well as going through the surgical side of things. So that's why I think it's really exciting, is that everybody's lived experience is going to be heard, and the potential is tremendous around that. So thank you.
Thank you, Stephen. This leads into perhaps a patient-related research question, and that is, Katie, maybe we'll begin with you. How do you make sure your research truly reflects the needs of all patients, especially people who haven't always been represented in your studies?
Solve that problem. Sure. However, I would say, it's too big, actually, that why you recognize that it's not unimportant to ask what happened. all of that matter. Of course, that it sort of sounds obvious, but it wasn't always the case. So I think that the way that we as an institution are moving forward is we are like mission partnership accountable. So you know, if patients want to give back to the institution, we have council or patient volunteers who sort of get to not only hear about what we're doing on the research side, on the clinical side, to get feedback. They get to then, if there is a research project that sort of is their interest, they can then essentially contribute to that. And we do that by not only involving our experience on our research team, they actually become a member of the team. So we're not just sort of come in to be part of the study. That sort of has used to be part of the research, but now they're actually helping us design. I'll give you an example. You know, I'll say sleep. Sleep is such a huge aspect of wellness and care. When we're designing studies, we sort of often care about how many more years, you know, how many fewer heart attacks do you have, how many, you know, whatever, how many events do you arrhythmia events do you have? Well, imagine if none of those changed with a particular intervention, like you slept better. Imagine if that's actually an outcome that you know, it's actually the main outcome of the study. Those are the kinds of things that patients bring to the study. They say, yeah, I did guess, like, of course, so I put this down longer, I guess, but I actually just want to feel better. I want to sleep better, and I want to stay longer, and I want to, you know, whatever the outcome is. And they can help us change the outcome of the study entirely based on deciding that those are the things that we care most about when we're research. And I'm what you call a basic scientist. I do the lab work, so I'm in the cells and the molecule. So you can imagine that cells don't really have experience. You don't think that necessarily patients, the contribution to the understanding of molecular biology, if that's not much of your background, it is fantastic, but actually it does really help because we sometimes when you're talking about a heart cell, excited the fact that you're studying that heart cell, you want to understand it more so that you can help treat or diagnose or prevent whatever. So it gives back to a lot of researchers in the lab that connection. And it also again helps us decide that actually we are going to change the way that we look at something. We are going to focus on how sleep affects those heart cells rather than being whatever. So we do change our outcomes, and that's what we do. And we're doing more of it. We're not perfect. We're just having too. Heather works in our research services office. She's helps kind of connect patient partners and families with our researchers and their teams. So if you're, you know, go talk to Heather if you're interested in something like that. She'll be able to sort of match make, I want to say, and she'll be happy.
Thank you. Jennifer, would you like to add anything to that?
I would add that another area that we've focused tremendously on at the Institute is women's heart health. And for years, for decades, a lot of our research has shown that typically we see about 20% of women in our clinical trials or other programs and 80% men. And this is not only here, but in many other institutes and settings. And it's the feedback from the patients, the female patients that have been in those trials, which have really advanced our line of inquiry, our research for women's heart health. So last year we launched the first Canadian women's only exercise trial, and you'll hear more about it this evening when we go to the booths. But it's because of the feedback we received from women in our clinical programs and in our research studies that we developed a trial that's exclusively for them, incorporating technology, offering a variety of formats, bringing the intervention as close to home as we possibly can. But that's because we created avenues for acquiring feedback from our patients and the general public, those that decide not to enroll in our clinical rehabilitation programs or in our research studies. Their feedback is very valuable because it allows us to design trials and projects that are more inclusive and that can include the very individuals that we need to study and translate our knowledge to. So I think feedback from patients can come in a variety of ways, whether it's an event such as this. It's those that have said no to our clinical programs for a variety of reasons. It's those that have said no to our research projects, but all of that feedback we do hear, and we try our very best to incorporate it in our projects moving forward. And I think our strategic plan that has been outlined with Dr. Beelan's at the helm, with Dr. Rayner and many others, really have tried to focus on inclusivity, broad reach, community involvement, and patient partnership.
One more thing, actually,
Absolutely.
Jennifer, you reminded me, sorry, Stephen, if I just may just want to add one thing, and my mic is on this time, so apologies. Yeah. Um, yes, yes, I do. Yes. So I just wanted to also say that what you mentioned about the women's heart health, that's a great example because, you know, women were so, I mean, are continued to be understudied, and, you know, so that's why we have the Women's Heart Health Center for so many reasons. But actually what we recognize is there are lots of groups of individuals who are not included in different, you know, whether it be studies so that we understand them or even treated differently, et cetera. So one of the things that we're going to be doing is we call it understudied diseases. They're not necessarily rare, because in fact, sometimes it turns out, like with women, you used to think heart disease in women wasn't common. It's very common. It just wasn't acknowledged or studied or diagnosed. So we're sort of calling it understudied diseases for that reason. So it's going to be looking at, for example, in younger people. Heard already about, you know, those who are diagnosed with heart disease in young, you know, if people think, oh, you're only 46, how could you? Well, it turns out it's actually not as uncommon as we maybe think. We just weren't looking. So that's another way that we're trying to center that as well. Go ahead, Steve.
Thank you. And both Jennifer and you stole my line on the women's heart health. And I think that's one of the key things that this institute has done well, is to recognize that and to set up a separate program for that, because so much of the medical science that we experience is based on data from men, and white men in particular. And I think so my experience going through the rehab program, and it has many different facets. It involves going through the physical side on the track, doing some psychological help in understanding the anxieties and this kind of thing. And what I was very privileged to be able to participate in that, because I had to be here twice a week. And I had a job where I could take the time off to do that. I had the money that I could afford to come and park the car there twice a week, et cetera, et cetera, et cetera. Well, it's 6:30 in the morning. It's relatively easy, not bad. But what struck me in talking to the other people that I encountered during the rehab program is that I was so privileged to be able to do that. There were people in there who they had to make a choice between, do I do rehab or do I lose my job? And that was a real thing. That's one of the women in the process. And I think this is the one of the issues, is that the people who can participate in the research are the ones who are probably the most studied already. So in our society, again, there are people living at the margins who are very susceptible to disease. And how do we understand the barriers that exist for them to participate in the research and get data from them? And then how do we help them overcome them? Because recognizing the barriers is one thing, but overcoming those barriers and getting them to be able to participate in research is another thing. And I think that's one thing, again, it's recognized by Tri-Council funding. And you see more and more, to get funding for a study, you have to have patient partners involved. There has to be a diversity of patient partners. So there are great moves ahead. There have been great moves in this area, but I think there's still so much work to do to recognize our population in Canada as a very kind of particular, diverse, multicultural population. Thank you.
Great. We'll move on to the next question. What needs to happen for research, and perhaps Dr. Beelands, you can start us off here, but what needs to happen for research to more quickly and effectively make its way into everyday patient care? And how can researchers, healthcare teams, and patients all work together to make that happen?
Yeah, so I think the communication events like this are a great help. Sharing is caring, and basically educating people, and that communication, that discussion is happening between patients and healthcare providers. So to find out what it is that's going to help uptake of that information. So I think that communication piece is absolutely key. And the participation of patients helps that. If you get people engaged in something, they become more amenable to what is being worked upon. They understand it more, and they talk to their friends about it. You can spread the word more. So having that communication piece, I think, is a vital element.
Great. Katie?
Yeah, so I was, one of the things that I will say is that I think research used to be just something that we did for other researchers. We didn't really think about whether or not it actually made it to the bedside or to patients or to individuals, and now we do. So the patient engagement in research will be one way, because again, you'll already be designing your research question based on what's most important. But the reality is that it's still, research does take a long time. So it really does need, again, I'm back to our excellent community to say, you know, these are things that we want. These are things that we would like to do. These are other, you know, things in our rehab program that I want to participate in and I think are best for us. I think that, so having, you know, whenever you can, share that experience and share it while you're here with your community, and just because that's how we decide what is the most important. Having the knowledge, I can tell you, we have lots of knowledge, tons. What is best, how to actually use it and change the course of how you know, how you behave in particular is very, very challenging without participation. So, you know, it's really you and your families, communities who say, this is what we want.
Jennifer, your thoughts?
Well, I'm going to mention something that probably the general public might not know about, and that's funding, money. So I'm going to give you an example. We want to move research to our clinical guidelines to improve patient care as quickly as possible. Once the research is produced, we want to move it forward. But what you may not know is that researchers, healthcare providers that are involved in research spend an enormous amount of time writing funding proposals. We have a special focus on patients with atrial fibrillation arrhythmias. And a few years ago, we started a clinical trial and we recruited about 50 some patients, but we needed to go back and secure additional funding. It was a project that had already been funded by CIHR, a randomized control trial, so a very robust designed project, but we needed additional funding for a variety of reasons. The pandemic hit, research became more expensive, recruitment took a little longer than we initially expected. But it can take, and it did take, over three rounds of funding to different funders. That can be a year and a half of time for someone to be refining proposals, submitting their research, waiting for feedback from peer review panels. The success rate in Canada across CIHR or some other funding institutions or opportunities can range between 10 to 20%. So imagine spending a year and a half writing research proposals, and even though your research proposal may be at the top of the pile, if they only fund 3 or 4 for that particular committee or 5 or 6 for that particular committee, you're looking at a 15% odds of being funded, and it could take you several rounds. So I think it's always important to share that message with the public because they may not understand why research can take so long. There's obviously the time it takes to conduct the research, but before that even happens, we are spending months, if not years, enhancing our proposals, using the data that's already available to us and sending it out to various funding agencies or looking for industry partners to support the work that we do. And that also involves those that are at the top of the pile. Those that are scoring really, really well, the success rates are still very low. And so it's why we need to champion everyone that we can to see the value in research, because research is what drives patient care. In the Institute and other institutes, we've always believed that research informs patient care. We want to provide the best patient care, which is informed by the research that we do. And so I just wanted to highlight the funding aspect because it may not be something that you're aware of, but I think it's important to share that with the public.
Yes, please, Dr. Beelans.
So, good. Can you hear me okay? Yeah. So there was a time when research was here and care was over here. And we're now moving into a phase where research is being translated. But what we want is that the two are integrated. What's called an integrated health system. So that research and care are intertwined. The research informs care, the care drives the research, and so on. And we also need to think about how people who are coming into the system how we can best use the information to help inform the questions that we have and answer them for the patient's interest. And so thinking about your own data, because the data is yours, your own health data, but how it can be used to help the overall population and understand disease better, because all the information is going to help us. And so we are looking at ways to help integrate that in a better way. So when you come in, how do we better use that? How do we get your permission to use your data to inform the research questions that will help better your care and the care of others? So that's another piece that I think is going to help us drive more information sooner, better, faster, for the betterment of all.
Stephen, do you want to say something?
No, go ahead, Stephen. Go ahead. No, no.
I've got just two small points to make. And one is having more events like this, as we've already said. And so getting the research results out into the community so that they can be, the impact of those results can be felt community-wide much more quickly, rather than relying on kind of a trickle-down effect from the scientist through your doctor, this kind of thing. I think that's one way the results can get into the community much more quickly. But the other thing I would say is, and speaking as a researcher myself, however great your research plan is, however good the funding is, if you get the funding, if you don't have any subjects to do the research on, you don't go anywhere. One of the things I see on the R&B when you're doing the continual reviews is how some amazing research projects stutter and fail because they don't manage to recruit enough people into them. Because if the public people are skeptical of science or they don't understand the benefit that their participation can bring to the science. So I would really urge everybody and anybody to put their name forward or to sign up with Heather in terms of understanding what research programs are being run and what you can contribute to them. So then, as Dr. Beaman says, it's joining it together. It's the community and the institution coming together. So those are the two small points I made.
Katie.
So I have one, so I'm going to tell a story, and it's from a speaker that came to visit us. And actually they're not a scientist or a physician here at the Heart Institute. So I must admit, other great research happens outside of the Institute. Don't tell anyone else. I know it's terrible. But anyway, I'm going to tell 2 points to that story, Jennifer, because he actually quoted 13 times he had to apply for federal funding for a trial. 13 different times. And that's about, 5 years or so worth of asking and refining and saying, this, please, this is important. Here was the trial. There's a little piece of tissue on the atrium of your heart that's kind of like a little nubbin. It's doesn't really have a purpose. Blood can clot in there sometimes, and that clot might cause a stroke. So particularly in people with atrial fibrillation, that irregular heartbeat. So his trial idea was, maybe if we close off that little nubbin that we don't seem to really need, we'll be able to prevent those clots and prevent those strokes. That was the trial. So again, years to get, to actually get the funding. But he was at an institute like the Heart Institute. He wasn't here, but he was like the Heart Institute. We participated in the trial that had support for him, that was able to give him funding in the meantime while he sort of refined it. And so it got him started, it got him going. And to the individuals who did not, so it's a randomized trial, which means, patients are just put into one arm or the other and nobody knows and it's random. One of the, the group that did not receive that little closure of the nubbin had a stroke rate that kind of just climbed up over time. So they had strokes, just this is something we see all the time. The individual that had the closure, almost none. So almost immediately they could see the effect of whether they closed this appendage or not. And so what now again, of course, eventually it got funded and the trial picked up and it was a landmark trial. And now this is something that, we consider all the time. And, so we can see the add-on effect, but his institution supported that. And that's what we do here. And so to Jennifer's point, the difference of being at an institute like ours is that we have fundraising. We have a wonderful foundation. I'm sure all of you have donated in some way to the institute. That's how we can do that. We can, while we wait for the federal funding to sort of, it's our turn to get. And while we, all those years that we keep going back and trying, we rely on those it's Heart Month, right? It's Heart Month right now. We're out there lighting the Capitol red. We have amazing community supporters who are just, giving us so much support. And that's what it can do. it allows, you know, trials like that to get started or to maybe continue if there's an interruption, because guess what? 5 years is never enough, et cetera, et cetera. So that's why. And the other thing about recruitment, Stephen, I'll also add that, you know, that's exactly right. These particular trials that we talk about, sometimes the recruitment is actually so fast that the trial ends early, and the data is so promising and so exciting. So that's what we want. We want the trials to end before they're supposed to end, because, you know, everyone has raised their hand and said, I want to be part of this. I'd love to be part of this. Sign me up, you know.
It's a great story. Right. So Camille in the back just gave us a lovely 5-minute warning sign. Very discreet, very well done. And for Camille, thank you. So we'll move on to a final question that everyone can address. And Jennifer, maybe we'll begin with you. Real life recovery involves more than physical healing. It includes mental health support systems, quality of life. How do you make sure your research captures these real world experiences?
I'm going to answer this question specifically from a prevention and rehabilitation, perhaps more rehabilitation angle, because I'm slightly biased in how we do things, hopefully, at least moderately well within rehabilitation. And that is, rehabilitation has always been at the Heart Institute a very multidisciplinary program. What does multidisciplinary program mean? It means we involve those with a variety of backgrounds for training and expertise. Our clinical psychologists, who we had several too highlighted here this evening, involves social work, nurses, physicians, exercise physiologists, our physiotherapists, dietitians, but it involves many different skill sets and expertise. And as a result of that, we've always collected data that involves what those professionals deem as important. That means that quality of life has typically been an outcome, a measure, if you will, that we collect during our rehabilitation programs. We collect information on quality of life, on mental health that includes anxiety, depression, stress, or loneliness. But we've always had a fairly broad view of health, and therefore we've included that as part of our measures. Now, if you participate in rehabilitation about 10 or so years ago, you used to spend several hours on our track filling out pages and pages of questionnaires. And I know it was very cumbersome. And if you were here at that time, we thank you so much, because that data is being used today in a landmark project that we've just recently completed. So if you find me later tonight, I'm happy to expand on it. But we've always included these broad measures, knowing that health goes beyond perhaps just the physical elements, and there are social and emotional elements that we want to capture as part of our program. So given the 5-minute warning, I will end there because I know others have.
Dr. Beelans?
Sure. So I'm going to use an example. This is actually a study that we were undertaking, and we were looking at stroke rates. And I actually thank to Sam, who is over here, also enables our patient partners, had recommended this person to be on our grant team. And basically, it was him who basically suggested that we add quality of life to our measurement. We hadn't had that. It wasn't really part of our original goal. So it was thanks to the patient's interaction that we were able to do that. The other thing, and this is a little bit more the earlier question, we had a problem. The condition we were looking at should have been about 1/3 women and 2/3 men. Like that was what we would have expected, but we were having trouble recruiting women into the study. So the things that we did, we actually called up the Women's Heart Health Center. We added women to the research team, and both patients and scientists, to help us understand why we weren't able to get women into the study, to find out what the barriers were for them. And it was through the patients that we were able to understand that better, and understand that what was important to the patients is not just the outcomes that we were initially interested in, but it was quality of life, it was mental health, and so on. So asking those questions, engaging the patients in the process is how we're going to get the the other thing that, you know, Katie talked about the understudied, but the other thing we're trying to look at is obviously heart health, but within the whole person health as part of our strategy as well. So back to you, Joel.
Okay. Stephen, we'll have you with your thoughts, no thoughts. And then Katie, would you like to wrap up with some final words?
I will say, I think that we saw tonight examples of how, I mean, I don't think anybody presented a single metric about heart function tonight, did they? I don't think anybody said, you know, you didn't have a heart attack, you know, it was all about the physical, the mental, the experiential, you know, family, et cetera. So I think we're living it actually right now, how we're incorporating it here at the Institute. And this particular group of researchers and this particular focus is on prevention and wellness and rehabilitation, which by definition is only partially by your heart, right? So I think that's a good, tonight was a good example of how we're doing that.
And I know next year a social robot will be playing this role. So thank you for this year. So I'd like to thank everyone for being here tonight and for joining us online. And now a very exciting part is to go across the hall into the rehab gym, where there are several booths set up that you'll find super fascinating. Thank you very, very much for your participation. Thank you to our panel very much.